Hello everyone, I am Cassie Bolado from Group 3, reporting about Introduction to Chemotherapy. So, our outline in this discussion, we are going to talk about brief historical background about chemotherapy, classification of different antimicrobial agents, principles of chemotherapy, selection of antimicrobial agent, complications of antimicrobial therapy, microbial resistance, combination of antimicrobial agents, and misuses of antimicrobial agents. So, first, we define chemotherapy. Chemotherapy is therapy of infectious diseases and malignancy by use of chemicals called chemotherapeutic agents. It may be defined as the treatment of systemic infection, which is caused by bacteria, viruses, fungi, protozoa, helminths, or etc., or malignancy with specific chemicals that have selective toxicity for the infecting organism or malignant cell with no or minimal effects on the host cell. The chemotherapeutic agents have minimal or negligible effect on hosts due to similarity between the malignant cells and pathogenic microbes. The treatment of neoplastic diseases with drugs is also called chemotherapy. Next, we define antibiotics, which constitute a large proportion of chemotherapeuticals. The word antibiotic is derived from antibiosis, which is opposite to symbiosis. An antibiotic may be defined as a chemical substance produced by microorganisms such as fungi, actinomycetes, or bacteria that suppresses the growth, multiplication, or may eventually kill the other microorganisms at a very low concentration, which includes antiviral, antibacterial, antifungal, or antiprotozoan antibiotics. Aside from the antibiotics, antiparasitic drugs are the next most important group of chemotherapeutic agents. This includes drugs used against ectoparasites or ectoparasiticides and internal parasites or anthelmintics or antiprotozoan drugs. Moreover, the use of drugs in treatment of malignancies comes under cancer chemotherapy. However, both anti-cancer and antiviral drugs exert poor selectivity. They may exert similar effects on normal cells as they do in the target disease cells of the host. Moreover, selective toxicity is an essential property of chemotherapeutics, which selectively target the pathogen. The basis of selective toxicity is variation in structural components and or metabolic processes between the host cell and the pathogens. Also, remember that both anti-cancer and antiviral drugs exert poor selectivity. Thereby, most of the antibiotics exhibit a great degree of selectivity, such as inhibition of bacterial cell wall formation, inhibition of bacterial protein synthesis, and bacteriostatic effect of sulfonamides due to PABA antagonism in folic acid synthesis. In inhibition of bacterial cell wall formation, note that mammalian cells lack of cell wall. Examples of drugs that are under this are penicillins or cephalosporins. In inhibition of bacterial protein synthesis, note that the presence of specific binding sites on bacterial ribosomes but not on mammalian ribosomes. Thereby, such examples of drugs include are tetracyclines, aminoglycosides, and more. Meanwhile, in bacteriostatic effect on sulfonamides due to PABA antagonism in folic acid synthesis, note that mammalian cells do not form folic acid from PABA, but utilize the preformed folic acid. So, before we begin about deeper discussions on chemotherapy, we should know the historical background as to how it started. The ancient Indian system of medicine, also known as Ayurveda, and Chinese medical literature recognized the therapeutic value of soil, plants, minerals, and metals in the treatment of infectious diseases like syphilis with mercury compounds and malaria with cinchona bark. Even in the present days of scientific advancement, the rural folklore medicine recommends several age-old remedies in treating carbuncles, boils, and many infectious diseases. The real breakthrough in use of synthetic chemicals for killing disease-causing organisms came with the discovery of bactericidal and antiparasitic activity of dyes like methylene blue and arsenicals like arsenophenamine by Paul Ehrlich, a German organ chemist in 1890 to 1910. He coined the term chemotherapy while using arsenical trypanosomicidal agents and also introduced the concept of chemotherapeutic index, which is the basis of present-day therapeutic index. The works of Ehrlich prompted search for newer chemicals as antibacterials, and he was rewarded with Nobel Prize in the year 1909. He is regarded as father of chemotherapy. Because of the direction led by Paul Ehrlich, another German named Gerhard Dumac and his associates in 1932 to 1935 discovered antibacterial activity of another dye which is called as the prontosil, which subsequently paved the way for the most popular antibacterials of the modern era, which are the sulfonamides. Dumac was also honored with Nobel Prize in Medicine in 1938. Following Gerhard Dumac and his associates, Pasteur and Jobert also showed bactericidal property of common bacteria against anthrax bacilli, which is the first demonstrated the phenomenon of antibiosis between organisms that are now the basis of antibiotics. Thereon, the golden age of chemotherapy began in the year 1941 when penicillin was used in treating human bacterial infections. Penicillin was originally a chance or accidental discovery by Alexander Fleming in 1928 while working at the St. Mary's Hospital in London. He found that contamination of culture plate of staphylococci by spores of Penicillium notatum prevented the growth of the bacteria. He then demonstrated that the mold elaborated material antagonistic to the growth of staphylococci and named the substance as penicillin. It was then established as an antibiotic by Florey and his associates in treating wounded soldiers during World War II, which then Fleming, Florey, and Chain were awarded Nobel Prize in 1945. Thereby, the Fleming's discovery paved the way for search of antibacterial agents from several fungi, actinomycetes, and bacteria. Years later on, streptomycin was isolated from Streptomyces gracius by Waxman in 1994. It was then the first ever discovered aminoglycoside antibiotic. The search continues to find newer antibiotics in place of the older ones to which the pathogen are becoming refractory. Moving on, we are now on the classification of different antimicrobial agents. Antimicrobial agents are then defined as synthetic as well as naturally obtained from microbial origin drugs that are used to inhibit or kill microorganisms. Antimicrobial agents are thereon classified based on antibacterial action, antibacterial spectrum, mechanisms of antimicrobial action, and based on sources. Furthermore, based on antibacterial action, there is the bacteriostatic and the bactericidal. wherein bacteriostatic refers to the suppression of bacterial growth and multiplication. Such agents or drugs include sulfonamides, tetracyclines, chloramphenicol, erythromycin, lincomycin, and more. Meanwhile, in bactericidal, these drugs or agents cause death of bacteria, wherein examples include penicillin, cephalosporin, streptomycin, kanamycin, colistin, bacitracin, and more. Meanwhile, based on antibacterial spectrum, they are further categorized into two, which is the narrow spectrum and the broad spectrum. Narrow spectrum are the antimicrobial agents that are effective against a limited group of bacteria. Examples include which are the against gram-positive, which is the penicillins, erythromycin, lincomycin, bacitracin, and more. Meanwhile, a narrow spectrum against gram-negative includes streptomycin, gentamicin, polymyxin B, and more. In contrast, in broad spectrum, they are effective against both gram-positive and gram-negative bacteria. Examples include tetracyclines, chloramphenicol, fluoroquinolones, and sulfonamides, and more. Moreover, as antimicrobial action are classified based on mechanisms of antimicrobial action, first include by inhibiting bacterial cell wall formation or causing its breakdown leading to death of the microbes. Examples include penicillins, cephalosporins, bacitracin, cycloserine, and vancomycin. Meanwhile, in altering microbial cell membrane permeability causing leakage of essential intracellular components, it includes polyene antifungal antibiotics such as nystatin and amphotericin B, which exert antifungal actions by binding to ergosterol of fungal cell membrane, acting as ionophores causing leakage of cations such as potassium ions from the fungal cell. Thirdly, by inhibiting synthesis of ergosterol in cell membrane of fungi, which includes antifungal drug itraconazole. Fourth, by disrupting the structural integrity of bacterial cell membrane, which is the cationic detergent antibiotics such as polymyxin B and colistin that interact with bacterial cell membrane and disrupts its structure causing bactericidal effect. Fifth is by interfering with protein synthesis in bacteria by the following mechanisms, such as altering with the action of tRNA for binding site on 30S subunit of bacterial ribosome, which includes tetracyclines. Also, by forming abnormal codon, which is the anticodon after binding to 30S subunit of bacterial ribosome, causing misreading of message, which includes aminoglycosides. In addition, by inhibiting of transpeptidation after binding to 50S subunit of bacterial ribosome. Example include chloramphenicol. And lastly, by inhibiting translocation of peptide chain from A site to P site by binding to 50S subunit of bacterial ribosome. Examples include erythromycin and lincomycin. So, lastly, based on interfering with nucleic acid synthesis by such mechanisms includes by inhibiting nucleic acid synthesis such as DNA and RNA. Such agents include sulfonamides and sulfones, which are PABA antagonists. Also, trimethoprim, pyrimethamine, and proguanil. They are which inhibit the dehydrofolate reductase. Also, by altering base pairing properties of the template, such agent includes proflavin and acriflavin, which cause frameshift mutation, altering the codons for synthesis of a new protein instead of the normal protein in the bacteria. Lastly is the inhibition of either DNA or RNA polymerase in bacteria, which includes rifamycin and rifampicin, which are anti-TB antibiotics that inhibit bacterial RNA polymerase. Also, ciprofloxacin and norfloxacin, which are fluoroquinolones that inhibit DNA gyrase. So, furthermore, classification based on mechanisms of antimicrobial action includes based on sources, which are the fungal origin, bacterial origin, and actinomycetes origin. In fungal origin, such agents includes penicillin, cephalosporins, and grisofulvin. In bacterial origin, such agents include bacitracin, polymyxin B, colistin, and tyrosine. And in actinomycetes origin, such agents include streptomycin, tetracyclines, chloramphenicol, and macrolides. Moving on, a successful chemotherapy is when the practice is based on such principles of chemotherapy, thereby when forgetting about the principles of chemotherapy, such practice may be improper or inappropriate that which may be harmful to the patient. So, the basic principle of chemotherapy is the selective toxicity. Keep in mind that the drug should selectively inhibit or kill the disease causing pathogenic organisms or cancer cells without affecting the host cells. Also, chemotherapy must be rational and needs to be supported by either a clinical or microbiological diagnosis to identify the pathogenic organisms. That is because nowadays it is common for the especially for Filipinos that they often ask their friends instead on what is usually needs to be medicated when he observed on these following symptoms on its pets. Well, in fact, it should always be guided by a professional so that we can avoid the adverse effects which that eventually cause more or harms more the our precious pets or animals instead. Furthermore, characterization of the pathogen or pathogens, including its sensitivity to an antimicrobial agent, is essential. This is because if you characterize the pathogen which you needed to inhibit or kill, thereby you can identify what type of agent is perfect for that kind of pathogen. Moreover, selection of an appropriate drug based on pathogenic organism, patient factors, and drug factors, if possible, it is better to use a narrow spectrum antibiotic, which is more selective and thus cause less interference with the normal resident bacteria. Because broad spectrum antibiotic are selectively inhibits or kills large or both gram positives or gram negative bacteria, which might be harmful to those of the normal or the bacteria that are helping the normal functioning of the body. Furthermore, the drug should be used in proper time by proper route at appropriate dose rate and for a proper duration. If an antibiotic is used, it is better to administer it as immediately as possible at a high dose for a short period and continue beyond 48 hours after disappearance of symptoms unless signs of toxicity are seen. This ensures that the organism is totally eliminated and there is less chance of developing antibiotic resistant bacterial strains. Moreover, the antibacterial activity of a given dose of an antibiotic is inversely proportional to the number of bacteria present. Therefore, earlier the treatment, there is more chance that the infecting organism to be caught in the early logarithmic growth phase. Also, attainment of effective concentration of a chemotherapeutic agent for a sufficient period at the site of infection or tissues or bodily fluids infected is very important. Also, specific and appropriate supportive therapy should be undertaken to overcome the infection. Now that we are done discussing on the different principles in chemotherapy, we are now moving on to the selection of antimicrobial agents. The choice of an antimicrobial agent in treating an infectious disease is based on the infecting organism, the patient, and the drug. In microorganism related factors, successful chemotherapy demands a specific diagnosis, but in the field conditions, it may not always be possible. In the general, the choice of antimicrobial agents is also determined by the choice based on clinical diagnosis of an infectious disease and also the choice based on microbiological culture and sensitivity tests. So, in the choice based on clinical diagnosis of an infectious disease, a preliminary clinical diagnosis should first be made to guess the likely pathogenic organism. In this case, neither the pathogenic organism nor its sensitivity is much variable, and therefore clinical diagnosis itself determines the choice of antimicrobial agents. Meanwhile, in the choice based on microbial culture or sensitivity test, in this case, it is neither possible to guess the type of infecting pathogen nor its sensitivity, which includes the osteomyelitis, meningitis, urinary tract infection, wound infection, bronchopneumonia, and more. In such cases, isolation, identification, and characterization of the causative pathogen, sensitivity testing, and determination of the minimum inhibitory concentration or MIC should be assessed to provide a sound basis for selection of the antimicrobial agents as well as its dosage regimen. So MIC is the lowest concentration of an antimicrobial agent that prevents the visible growth and multiplication of bacterium after 18 to 24 hours of incubation in vitro. Meanwhile, the minimum effective concentration is the lowest concentration of an antimicrobial agent that prevents the visible growth and multiplication of fungus after 18 to 24 hours of incubation in vitro. Meanwhile, the minimum antibiotic concentration is the lowest concentration of the antibiotic at the site of infection that reduces the growth of bacteria in vivo, which is about one-tenth of MIC. Lastly is the minimum bactericidal concentration, which is the lowest bactericidal concentration of antibiotic that results in 99.5% decline in bacterial count in vitro. However, under field conditions, it may not be always possible to ascertain the aforementioned considerations, and the situation may be as follows, especially when the bacteriological laboratory facility is not available. In such case, broad spectrum antimicrobial agents such as tetracycline, fluoroquinolone, sulfonamides, or combination of antibiotics like penicillin and streptomycin or gentamicin, cephalosporin, and metronidazole for anaerobic infections should be administered to cover all likely bacterial pathogens. Also, when bacteriological laboratory facilities are available. However, the treatment cannot be delayed. Examples include acute mastitis in cows, septicemias, meningitis, and more, where the specimens should be sent first for microbiological examination, and treatment also should be started as in if adequate response is not found, then the antimicrobial agent is changed later as per bacteriological findings. Lastly is when bacteriological facility is available and treatment can be delayed for some times. Examples include chronic mastitis, chronic urinary tract infection, and more. In such situations, it is better to wait for microbiological culture and sensitivity report, and then the therapy is started on the basis of microbiological findings. Meanwhile, in animal related factors, it includes the age, functional capacity of kidney and liver, host defense status, pregnancy and lactation, drug allergy and idiosyncrasy, presence of blood, pus, CSF and tissue breakdown products, location of infection, and effects on antimicrobial agents on intestinal microflora. So, in the age, it is one of the important factors determining the pharmacokinetic properties of the drug. So, aminoglycosides are excreted slowly in old animals because of poor renal function, and therefore, full dose of the drug may cause toxicity. In contrast, newborns cannot metabolize and excrete chloramphenicol because of deficiency of metabolizing enzyme that may cause fatal gray baby syndrome, which is shown that gray discoloration of body, flaccidity of muscles, and hypothermia. Also, tetracyclines are contraindicated in young animals and children as they accumulate in developing teeth and bones, which in turn discoloration and weakening. Next is the functional capacity of kidney and liver. Antimicrobial agents with low margin of safety must be used very cautiously when the renal and hepatic organs of disposal functions are defective. Drugs like cephaloridine, nalidixic acid, tetracyclines, aminoglycoside, amphotericin B, and more should not be administered in renal dysfunction. On the contrary, erythromycin, chloramphenicol, rifampin, and more should not be administered in liver diseases. Next would be the host defense status. Integrity of defense plays an important and critical role in the final eradication of the pathogens, especially when a bacteriostatic drug is used. So these bacteriostatic drugs cure an infection in a patient with normal defense status, which in they are immunocompetent. But bactericidal drugs must be given in a patient with impaired defense because bacteriostatic drug will be less effective in very young, very old, and debilitated animals because of poor or impaired host defense, such as in phagocytosis and immunity. Next would be the pregnancy and lactation. It is better to avoid all antimicrobial agents during pregnancy, particularly during the first trimester period of organogenesis, unless it is very much essential because this may cause abnormality in the fetus, wherein the teratogenicity of tetracyclines, fluoroquinolones, or aminoglycosides. On the other hand, penicillins, erythromycin, and some cephalosporins can safely be given in animals. Also, nalidixic acid and sulfonamides are excreted through milk and may cause hemolysis in glucose 6 phosphate dehydrogenase deficiency. Thereby, chloramphenicol, ivermectin, and many other antibiotics and anthelmintics cannot be given to milch animals producing milk for human consumption because of possible human health hazard due to presence of residues in milk. Furthermore, in drug allergy and idiosyncrasy, If there is any previous history of allergic reaction of an animal to an antimicrobial agent, the drug should not be given in that animal. Antibiotics, especially penicillins, produce life-threatening severe anaphylactic reactions in man and sometimes in animals, wherein aminoglycosides, erythromycin, and sulfonamides, trimethoprim, are often associated with allergic reactions and should not be used in allergic patients. Thereby, individuals genetically deficient in glucose 6-phosphate dehydrogenase enzyme, when treated with primaquine, fluoroquinolones, sulfonamides, may suffer from hemolysis. Next would be the presence of blood, pus, CSF, and tissue breakdown products. They interfere with the efficacy of many antimicrobial agents such as sulfonamides, nitrofurans, and aminoglycoside antibiotics, whereas these factors do not affect the efficacy of penicillin. Second to the last will be the location of infection, which determines the choice of antimicrobial agent and route of administration, in which the presence of infection behind the barrier, such as meningitis, abscess, and more. Last would be the effects of antimicrobial agents on intestinal microflora. Ruminants are highly dependent on the integrity of the ruminal microflora, and thus oral administration of broad-spectrum antimicrobial agents such as tetracyclines, chloramphenicol, and more affects the normal flora and leaving the field free for growth and multiplication of pathogenic yeast and fungi, which results in acute diarrhea, especially on ruminants. Meanwhile, on drug-related factors, this includes the sensitivity of the organism to the antimicrobial agents, type of antibacterial activity, antibacterial spectrum, combinations of antimicrobial agents, pharmacokinetic properties, dose of the antimicrobial agents, route of administration, and toxicity. In the sensitivity of the organism to the antimicrobial actions, an antimicrobial action to which the organism shows the highest sensitivity is selective. Thereby, the sensitivity of a microorganism different antimicrobial agents is determined on the basis on MIC. An organism is considered highly sensitive if the MIC of the antimicrobial agent is lowest for that organism. Next would be the type of antibacterial activity. A bactericidal antimicrobial agent is preferred over bacteriostatic in a patient with impaired host defense, in serious life-threatening infections, and when the infections are behind the barriers. Meanwhile, in antibacterial spectrum, if the characterization of pathogen is possible, then it is far better to use a narrow spectrum antimicrobial agent, which selectively affects the pathogenic organism without much affecting the normal microflora. But when no guess can be made about the nature of organism, usually a broad spectrum antimicrobial agent is to be used to cover all likely pathogens, but problem of superinfection has to be borne in mind, in which the superinfection will then be further discussed later on. Next would be the combination of antimicrobial agents. Combination of two bacteriostatic drugs is additive. So in combinations of tetracyclines, chloramphenicol, erythromycin, or synergistic potentiation such as sulfonamide and trimethoprim, this combination of two bactericidal drugs is also additive if the organism is sensitive to both, such as penicillin and streptomycin. But the combination of bactericidal and bacteriostatic are frequently antagonistic, such as penicillin and tetracycline or chloramphenicol for pneumococci. and nalidixic acid with nitrofurantoin for E. coli, and hence are not combined. Inhibition of bacterial growth with combination of antibiotics is called antibiotic synergism or potentiation, where their concentration is less than or equal to 25% of the MIC of each antibiotic acting alone. Thereby, inhibition of bacterial growth with combination of antibiotics is antibiotic additive effect, where their concentration is equal to 50% of the MIC each antibiotic acting alone. The fraction of the MIC, which is the FIC, of an antibiotic required to inhibit the growth of bacteria in combination when more than 50% of MIC of each antibiotic is required to inhibit the growth of bacteria, it is then called the ineffective antibiotic combination, which then indicates the unviable combination of antibiotics. Under these circumstances of antimicrobial combination, the FIC is less than 1, which is equivalent to 1 and more than 1 respectively. Furthermore, in the pharmacokinetic properties, penicillin G is destroyed by gastric acids, while aminoglycosides are not absorbed orally. Also, chloramphenicol in ruminants is degraded by ruminal flora. Thereby, the aforementioned agents or drugs cannot be given orally and are given parenterally. Aminoglycosides cannot pass through the blood-brain barrier and are ineffective in bacterial meningitis, whereas sulfadiazine, chloramphenicol, cefotaxamine, and rifampin can pass through BBB or the blood-brain barrier and attain high concentration in CSF and are the preferred drugs in meningitis. Also, penicillin cannot readily pass across the pleural or peritoneal membrane, whereas chlortetracycline does the same readily. Ampicillin, on the other hand, and erythromycin attain high biliary concentrations and can be given in biliary tract infection. Also, the dose of the antimicrobial agent is wherein at the start the animal needs to be administered an initial leading loading dose or priming dose to produce effective MAC, followed by repeating the dose intermittently at specified intervals and for required duration, called pulse dosing. The pulse doses may be lesser than or equal to the initial dose depending upon the antimicrobial agents, wherein the priming dose establishes the therapeutic antimicrobial concentration and the pulse dose continues to maintain that level. Thereby, it can also be called as maintenance doses such as sulfonamides. However, several antimicrobial and other drugs are administered at fixed predetermined intervals at the same dose level, similar or initial and maintenance doses. Some antibiotics, such as aminoglycosides, fluoroquinolones, and imipenem, exhibit antibacterial effect called post-antibiotic effect or PAE, which is a measure of the persistence of antibacterial action after the withdrawal of antibiotic. Furthermore, in the route of administration, the effective plasma concentration of antimicrobial agent and their subsequent maintenance depend upon the route of administration of the drugs. The IV route is preferred in life-threatening serious infections, whereas oral antimicrobial therapy is generally preferred in monogastric animals and young ruminants, but oral use of antimicrobial agents in ruminants is not advisable because of erratic absorption in large rumen and destruction by ruminal microflora, except for enteric infections. Next would be the toxicity. If a number of antimicrobial agents having similar efficacy can be used for the treatment of an infection, the least toxic antimicrobial agent is the preferable. one to choose. Such examples include penicillins, cephalosporins, erythromycins are preferred over aminoglycosides, tetracyclines, chloramphenicol, and vancomycin. And AMA or antimicrobial agents should have wide chemotherapeutic index, wherein the ratio of median lethal dose to the median effective dose of a chemotherapeutic agent that is wider the ratio, safer the antimicrobial agents is to similar to therapeutic index of the other drugs. The last two would be the risk of development of drug resistance among the microbes and residues in the milk products, meat, and eggs, which must be considered. And lastly, in the drugs related factors, the cost of antimicrobial agents should be less costly and is generally preferred than the expensive one without compromising the efficacy. Moving on to the complications of antimicrobial therapy. First off, toxicity. Many drugs like tetracyclines, erythromycin, and chloramphenicol are irritants and may cause pain and abscess formation on IM injection or thrombophlebitis of injected vein on IV injection. Different antimicrobial agents then show their dose-related characteristic organ toxicities, such as aminoglycoside that are ototoxic and nephrotoxic. Next would be the tetracyclines that are hepatotoxic and nephrotoxic. Next would be the chloramphenicol, which causes bone marrow depression and aplastic anemia. But penicillins and certain cephalosporins and erythromycin are least toxic and they have high margin of safety. Meanwhile, in allergic and idiosyncratic reactions, all antimicrobial agents are foreign to the body and are capable of producing hypersensitivity reactions, and these may be in the form of mild skin rashes or a severe anaphylaxis. Sulfonamides, penicillins, aminoglycosides, and cephalosporins are most common offenders wherein individuals genetically deficient in glucose 6 phosphate dehydrogenase enzyme, when treated with primaquine, fluoroquinolones, or sulfonamides, may suffer from hemolysis. These reactions are independent of the dose of the drug and cannot be predicted. Next would be the superinfection, which should be the most wary of, wherein it is the development of a new infection in the patient due to the use of antimicrobial agent for chemotherapy, especially following treatment with broad spectrum antibiotics such as tetracycline, chloramphenicol, or combinations of antimicrobial agents used. So, this is why we should be more wary of or be critical on the and choosing of antimicrobial agents because too much of it on the host or the patient would make it a more leading to a new kind of infection, which is an infection on top of another infection. However, it can be avoided by using narrow spectrum antibiotic whenever possible and by preventing indiscriminate use of antibiotics. Moreover, superinfection is more seen in intestine causing fungal or bacterial enteritis and respiratory tract and urogenital tract in which there is a superinfection with Proteus and Pseudomonas. Following superinfection would be the microbial drug resistance. It is the insensitiveness of a microorganism to an antimicrobial agent. Such example include staphylococcal resistance to penicillin G and enterococci to streptomycin. Lastly, in vitamin deficiencies, vitamins B and K are synthesized in the GI tract of man and animals. use of antimicrobial agents interferes with normal intestinal flora, particularly in herbivores, and therefore vitamin synthesis, which thereon may result in vitamin deficiency in man and animals. Now that we are done on discussing about the selection of antimicrobial agents based on the infecting organism, patient, and the drug, we are now moving on to the microbial resistance. So, types of bacterial resistance to antimicrobials include the natural resistance, wherein some bacteria are inherently insensitive to a particular antibiotic, such as the E. coli bacteria, are naturally resistant to benzyl penicillin, which are unable to penetrate the cell wall. Another is gram-positive bacteria are usually susceptible to some antibiotics, which are ineffective against gram-negative bacteria and vice versa. In contrast, acquired resistance are when previously sensitive bacteria become resistant to an antibiotic, wherein the process is called acquired resistance. This is due to replacement of sensitive bacterial population by resistant population. The acquired resistance is through genetical or biochemical mechanisms. Indiscriminate use of antibiotics, such as improper selection of an antibiotic, underdosage, or treatment for longer or shorter period than required, which thereon promotes acquired resistance. Under microbial resistance, there is also called a genetic change in which involves one or more of the following mechanisms such as mutation and transmissible resistance, wherein mutation occurs when some mutants that are relatively resistant to antibiotic that exist in a large susceptible bacterial population. This is due to sudden change in the chromosomes of such bacteria. The change is then passed on to the succeeding generations, resulting in growth and multiplication of resistant mutants. Moreover, in the transmissible resistance, the resistance is due to transfer of resistant genetic material from bacterium to the other through transduction, transformation, or conjugation will be discussed on the next slide. So, in transduction, it involves a bacteriophage, which is a virus that infects a bacteria that carries the DNA from the bacteria resistant to an antibiotic to new bacteria, which also subsequently become resistant to that antibiotic, which refers to the transfer of penicillinase code among the Staph aureus bacteria. The process occurs among both gram-positive and gram-negative bacteria. In addition, transformation results from transfer of free DNA from one bacterial cell to the other. The recipient bacteria become resistant if the DNA codes for resistance. Last would be under genetic change would be the conjugation, which refers to the transfer of genes from one bacterium to another by a direct contact through a surface structure such as sex pilus or bridge. The DNA coding for antibiotic resistance is transferred from the donor cell into the recipient cell through conjugal transfer. The recipients then turn into donors and the resistant population is built up rapidly. The conjugal transfer of resistant genes is reported in the gram-negative bacteria. Not only occurs between the bacteria of the within the same species such as E. coli, but also occurs predominantly between species of different species of gram-negative bacteria, between E. coli and Salmonella spp. Thereby, conjugation is the most common mode of developing resistance among bacteria. Furthermore, another type of resistance wherein the bacteria exhibits is cross resistance, where the bacteria developing resistance to an antibacterial also become resistant to other antibacterials of similar type. This is due to the identical mechanism of antibacterial actions of the antibacterial agents used. Such examples include bacterial resistance to sulfonamides, tetracyclines, penicillins, and more. So, with all those problems because of resistance, how do we curb drug resistance? For clinical efficacy of an antibacterial, it is essential to prevent drug resistance, which is to combat the problem of resistance. The following measures should be considered as such. The summary of the previous mentioned, which really should be given attention of, wherein every effort should be made to use antibiotics only when the clinical indications are clear. Do not use antimicrobial agents if the diseases is not infectious and treatable or self-limiting, because most often times, especially when there is self-diagnosed owners of pets, or especially backyard farmers, they usually diagnose themselves usually with antibiotics, even though it is not really diagnosed as an bacterial causing disease. And this may greatly harm the patient or the animal itself, which then gives rise to drug resistance. Also, information regarding endemic infections and sensitivity patterns should be considered before selection of an antimicrobial agents. Avoid overuse of newer antimicrobial agents when an already available drug is equally effective. So don't jump to a newer antimicrobial agents. So you first try to use the ready available drugs that are known before, and then before you can use the newer one, because most often the the older generation of antibiotics, or the more readily available antibiotics, are more preferred, because when you are resistant to those already antibiotics, you will then resort to the newer antibiotics. Thereby, if you immediately resolve to the newer antimicrobial agents, then it would be hard for you to find another antimicrobial agents that you are not resistant to. Next would be, if an antimicrobial agent is needed, a narrow spectrum antimicrobial agent should always be preferred whenever possible, unless of the regarding conditions that was aforementioned. Also, prefer rapidly acting and bactericidal drugs, particularly where host defense is impaired. In combination of antimicrobial agents against resistant organisms, the individual agents should be used in full doses. Also, broad spectrum antibiotics should be used only when a narrow spectrum drug is not effective against the organism or unsuitable for the animal. Next would be indiscriminate use of antimicrobial agents should be stopped, wherein the antimicrobial agent should not be used at subtherapeutic dose or unnecessarily for an extended period. Moving on, combinations of antimicrobial agents should not be combined indiscriminately or without justification, but sometimes they are used in combination with specific objectives. Objectives include to achieve additive or synergistic effects. Next would be to broaden the spectrum of antibacterial activity, wherein it is necessary in the treatment of mixed infections and in severe undiagnosed bacterial infections. Combination should not be the substitute of accurate diagnosis. Next would be to curb the development of drug resistance. This is very important for the treatment of diseases where the organism is notorious for developing drug resistance, and for chronic infections requiring prolonged antimicrobial therapy. The last would be to decrease the intensity of toxic effects. Drugs having low therapeutic index when used in their full doses precipitate toxicity. If such a drug is combined with another synergistic drug, In reduced doses, its toxicity can be reduced, such as amphotericin B combined with flucytosine combination is used for cryptococcal meningitis, wherein a shorter course of treatment is needed when amphotericin B is used alone. So, to further discuss how to achieve additive or synergistic effects, the rules regarding combinations are when additive are become the product when bacteriostatic and bacteriostatic are combined. Also, when bactericidal are combined. However, sometimes there is synergistic result when bacteriostatic and bacteriostatic drugs are combined. Next would be how about when bactericidal and bacteriostatic are combined? So they are generally antagonistic. So they are usually not recommended to be combined since they are antagonistic. Next would be the synergistic combination are used in full doses of individual drugs for achieving the goal. Another term to encounter would be chemoprophylaxis, wherein it is the use of an antimicrobial agent to prevent the setting in of an infection in the body or to combat a contacted infection before its final clinical manifestation. It reduces the number of the viable microbe below the critical level, thus preventing infection. The chemoprophylaxis may be done against specific organisms generally highly satisfactory, such as tuberculosis in man with isoniazid, or for prevention of infection in some high risk situations, such as urinary tract catheterization, which may be satisfactory. But it is highly unsatisfactory and condemnable, even hazardous, if it is done for prevention of infection in general. So, finally, the final topic for our outline in the introduction of chemotherapy, which be the misuses of antimicrobial agents. These are very important, especially to be noted of to avoid the improper or to avoid an unimaginable or the unlikely result of the antimicrobial agents when regards to the treatment of the patient or the animal. Thereby, misuses of antimicrobial agents includes treatment of untreatable diseases such as use of antibiotics in viral diseases. So this is very wrong because when you think of treating of viral diseases, then you use antiviral agents. However, you should only use antibiotics because it for against bacterial causing diseases, which is called antibiotics. Next would be the improper dosage. Antibiotics should be administered at adequate therapeutic doses. Their suboptimal dosage will not suppress the bacteria and at the same time may precipitate development of resistant population. Thereby, administration of higher doses can cause toxicity to the host. Again, would be the superinfections, wherein the use of oral antimicrobial therapy, especially in broad spectrum antibiotics, suppresses the normal ruminal or intestinal microflora, leading to development of enteric infections by the invading pathogenic microbes. Next would be inhibition of starter bacteria. Use of antibiotics in dairy animals results in excretion of significant levels of antibiotics through milk, which may suppress the starter bacteria. Also, antibiotics used as promoters. These are very wrong, wherein the antibiotic promoters in feedlot animals before slaughter without observing withdrawal specifications may pose public health hazard. Lastly, would be the applications of antibiotics in surgical wounds without proper drainage. Use of antibiotics to prevent bacterial infections without removal of necrotic tissue debris or providing proper drainage for the purulent exudate results in markedly lowered antibacterial potency of the antibiotics. So much for the long discussion about introduction to chemotherapy. Thank you for listening.